EM board bombs.
Welcome to EM Board Bombs. What's up, Briggs?
EMBB, we're back. Better than ever.
Back. Better than
After
ever.
the rush of the IT.
Guess who's back? Guess who's back? It's like the Eminem song.
Yeah, I don't know if we could play that and get blocked on Apple.
No.
Explicit
That would be
content.
bad news. Yeah, ITE, I think, finished up technically, right?
It
As of
did.
a few
It did.
days ago.
For most
as
people, yeah.
reporting.
There are a few exceptions.
Yeah. Hopefully it went well. We had a bunch of kind of rapid Perl ITE YouTube shorts and things like that.
Appreciate the shout outs on social.
Yeah. Shout outs on social. Also, I think in aggregate, a couple thousand views
Right.
of some of those things. So that's great.
Right.
That's awesome.
Right. All right, on to the next test.
I know. Right?
Spring board season.
I know. Hey, let's just a quick shout out to our main sponsor,
Yes.
EM News.
Emergency medicine news, baby.
Yeah,
You got it.
Emergency Medicine News, only sponsor. That's it. And we're going to just dive right into, I think, a timely question. I don't think this is a controversial question. I mean, some might say it's maybe a bit of a controversial topic, but
It was in the news recently.
Yeah, it's been in the news. But let's just get into it. All right. A 3-year-old unvaccinated boy is brought to the emergency department with a 4-day history of fever. Temperature is 103, cough, runny nose, and red eyes. Today, his parents noticed a red, blotchy rash that started on his face and is now spreading towards his trunk and extremities. On exam, he has conjunctival injection and small white spots on the buccal mucosa opposite the lower molars. Which of the following features would best help distinguish measles from other viral exanthems? And I know you were thinking, like, oh, I got this, it's measles. No. The test question is
It's a
telling
step
you,
further.
it's measles. But how are you making that dreaded kind of distinction, right? Which is like so hard to make. Is this just another viral rash or not?
Exactly.
So again, which of the following features would help best distinguish measles from other viral xanthems? Tough one. Is it A, rapid onset high fever followed by a rash that starts on the trunk? Is it B, a pruritic rash that spreads cephalocaudally with post-auricular lymphadenopathy? Is it C, diffuse erythematous rash with a sandpaper-like texture and a past history of sore throat? Or is it D, a rash that begins at the hairline, then it spreads downwards and is preceded by cough, coryza, and conjunctivitis? Before we get into it, though, shout out EM Rapid Bombs.
Yeah, shout out.
You can go to our website, emboardbombs.com, click on that question bank that we have. We have about 500 question answer podcast episodes. Everyone knows question banks can really help you just retain information, learn information. We're the only question bank that has an audio format, though, that is specifically designed for board review. Only one on the planet. It's pretty cool.
That's crazy. We don't know about Mars, though.
That's true. We don't know about Mars. But anyways, check it out. You can go to emboardbombs.com and click on Question Bank, and you can do one-click sign up there. It's pretty awesome. A lot of people have used it for ITE board review. Also, we appreciate the shout-outs. We've got a bunch of emails, especially recently, folks who used it for ITE board review to help do better. We always appreciate those emails and the shout-outs that we get. Hey, so the correct answer here is going to be what, Briggs?
Choice D, rash that begins at the hairline, spreads downward, and is preceded by the infamous 3 C's, cough, coryza, which is a fancy word, and conjunctivitis. That is so classic for measles. So we're talking about differentiating measles from just another virus. Right. Walk out of the room, and I've had many a resident tell me, it's just a virus. Just
something we're going to have to deal with and know how to really distinguish. And that's, I think, a big part of this, right, Briggs? Is I think everyone knows the 3 C's. You learn all about that, but then it also is like, what are some of the other distinguishing features, right?
Exactly right. Yeah, so the biggest one is the MMR, right? And that's what we're going to focus on: measles, mumps, and rubella, which is German measles. But it's always called rubella. And then there's some other answer choices here that we mixed in here. One was the scarlet fever, which was that sandpaper thing we'll get into. And then rubeola infantum, as well as erythema infectiosum. Wow, that's like a blast from the past if you're a resident or an attending listening to this. So like, I learned that at one point. I kind of forgot them. So let's just dive in, talk about each of the key features, just to know the differentiating features of these. So measles, the 3 C's, cough, coryza, conjunctivitis. Now, you're probably thinking to yourself, first of all, what is coryza, which is essentially a nasal cold? That's it. It's a fancy word for that. Yeah. And how does that different from any other virus? Well, it's not. It's all the same. Cough, coryza, conjunctivitis. The biggest high yield features here is going to be the extreme height of the fever. This is not just like a child that comes in and the mom says, hey, they had a fever at home and they felt warm to touch or something like that. No, this is a fever that's usually greater than 101, greater than 102. These are extremely high fevers. And then these things called these Koplik spots, which sounds just like board relevant, and I couldn't tell you the incidence of these. I don't think we know the incidence of how common Koplik spots are because measles is not that common, but it's just small white spots on the bulk mucosa. They have to mention this because they have to mention something that's so distinguishing measles from other viruses. And then the classic rashes that starts at the hairline, spreads from the head down to the trunk.
I think that's a key one, Briggs. Sure. I think that's really a key one, is starting at, again, the hair, face, trunk, extremities. That right there, I think, is a big one because, again, Koplik spots sometimes are really hard to appreciate.
Yeah, Koplik spots and then the rash that does that characteristic pattern. Yeah. And the preceding URI symptoms. But the URI symptoms themselves are not unique.
Exactly.
Comparing that to rubella, why don't you get into that?
Yeah, so rubella, you're thinking
German
more
measles.
low-grade. Yeah, more low-grade fever here.
Those sneaky
mild
Germans.
URI symptoms. Stop it. And then you have, again, some lymphadenopathy with that. And when you think about the rash here, starts on the face, spreads downwards within 24 hours. But this rash, one of the key things here, it fades much faster than measles. And you're not seeing Koplik spots, right? So oftentimes these kiddos, that rash is already gone sometimes by the time they see you. And it tends to go away much faster.
Okay, so the biggest thing I'm taking away from German measles is that it's wimpier.
Exactly. Yeah.
Lymphadenopathy with a wimpy rash.
Yeah, like not really running high fever. Exactly. Yeah. Correct. Yep.
All right, next one is rubeola, which sounds like a lovely name.
It does.
High fever, then a rash. That comes up after the fever. Not really helpful here. Not really helpful. But the key thing here is that it starts on the trunk and then it moves to the face.
Yep.
So it starts central and it moves out.
And then that last part is like fever resolves before rash onset. Right.
That's a tough one. There's nothing really distinguishing about that. They're going to throw you a bone about that one.
Yeah. And I think a lot of this too is distinguishing like some of these things that you're like, I'm not as worried about versus measles. Right, because like once you're like,
there's one that's more
there's
concerning.
so much other stuff that needs to happen.
Sure.
Yeah. So the hope is, and this is actually like a real life scenario that I had dealt with before in the past. That's why I kind of made the question the way it is because things go from 0 to 100 if you are worried about measles, right? Or everything else that we talk about, we're like, take some Tylenol, go home.
Exactly.
Right? For the most part. For the most part. Yeah.
Scarlet fever, this is the only bacterial one we have on our list here. This is actually a frequent infection just because of the nature of strep throat. So this is a generalized, group A strep infection, fever, sore throat, the Pastia lines, which sounds very Italian, and then what's called the strawberry tongue. The biggest thing to remember here is strawberry tongue and sandpaper-like rash throughout the whole body. Keyword, sandpaper rash. And this is this strep pharyngitis type of discriminating rash. Yeah. Now we talked about in the rapid bombs before between the difference between scarlet fever as well as Staphylococcus scalded skin syndrome, which I always have to pause and say very slowly because it's a lot of S's. But these two conditions are very distinct and very different. But they're both bacterial, and they both are treated with antibiotics. So we're not going to get into the particulars of that. You can check out our rapid bombs for more details. But just know that's the one that stands out here. And I believe that was choice C. That was a diffuse erythematous rash with a sandpaper-like texture and a past history of strep throat.
they love the buzzword sandpaper,
And strawberries.
like rash. They
And
love that.
strawberries.
And then oftentimes, they might not even give you the text strawberry tongue, right? But they might just show you a picture
Big tongue.
of a kid with the tongue, right? They'll just show like a kid's tongue sticking out. And this is what it looks like.
And it'll either be scarlet fever or Kawasaki's. That's what they're going to go with that.
Exactly.
Yeah.
Exactly.
Yeah.
Exactly.
Hey, this last one here, erythema infectiosum, also called the fifth disease. Now, this is, I'll never forget this. What is the classic word we always use with this one? I always remember this.
I know. It's
Go ahead and say it.
slapped
Say it.
cheek.
Slap cheeks.
Slapped cheek,
Yeah.
Yeah. So I mean, this is one that even like adults can sometimes get,
Sure.
right? So, but in adults, oftentimes it's the
Minus the
arthralgia.
slap
They have some
cheeks.
sort of like polyarthralgias that they'll have. Yeah, they won't really have the slap cheek, but oftentimes like adults will get that lacy reticular rash on the extremities. They'll literally sometimes show you like a picture. I've had this done before, where like they'll show me a picture of like this lacy reticular rash on their extremities, and then they have developed like subsequent like polyarthralgias and things like that.
Can you imagine trying to call out of work? I'm just imagining that, you have a high fever, you wake up and you look in the mirror and your cheeks are red and you call in and you're like, I got it. I have the slap cheeks.
I have this slap cheek.
I
And
can't- I
adults
can't come
though,
to
they're
work.
not really. It's more lacy. Again, for adults, more lacy reticular rash, right? But again,
You
the
would
slap
say
cheek one
lacy
is
reticular
another one.
rash. You academician.
But I will say this though, they will show you a picture of like a slap cheek
Of some slap
appearance.
cheeks. Slapped looking
You know,
cheeks. Yeah. The worst name ever. There's so many inappropriate, pediatric
I know.
names
Like
and
who
diagnoses.
thought about it too, right? When they were sitting
Yeah.
there, they're like they couldn't
Well,
really said
obviously we
super
know who.
red cheeks,
Obviously we know
okay,
who.
we're not gonna let's just
Yeah.
not. This is already a controversial topic enough. We're gonna keep going. All right.
Yeah.
We're just we're straight shooters. We don't
Straight
dive
shooters.
into
Hey, what's the
that
one
other stuff.
complication that you have to keep in mind from erythema infectiosum?
Yeah, sure. So erythema infectiosum, right? So it can cause a plastic crisis in sickle cell disease.
Right.
So this is one to know about that, and then it does actually. This is with that one rash that does worsen with like heat, sun exposure.
Yeah.
So we went through like a couple of these. We're gonna kind of summarize it more at the end here, but it's really important to also talk about measles complications because that's another one. Again, these are bunny questions that we're going to give you. So this is going to help you with like multiple questions here. So let's do a quick short on just measles itself and some of the distinguishing characteristics from other viruses. So measles itself, let's go. What are the key things?
Yeah. So the biggest thing that's going to separate measles from a typical viral exanthem is going to be one, these Koplik spots, which sounds just like a test high yield answer, and it is, but in real life too, look for it. Tiny white spots on the buccal mucosa. These are pathognomonic for measles. It's a really high fever. This isn't just a subjective, I feel warm or 99 or 100, whatever it is. This is like 103 and above. Like
And
102
before
and
the
above.
rash.
Bingo.
Before
Yep.
the rash, right?
The big 3 C's they always say in measles, cough, coryza, conjunctivitis, I don't think are helpful at all. Just URI symptoms. It doesn't really matter. And then this classic rash, the classic rash that always starts at the face and moves to the trunk and then goes out to the distal extremities. This happens over days. In contrast, rubella and the other infections happen a lot faster with a lower fever. So really high fever, Koplik spots, and a rash that starts in the head and goes down. That's so
Face,
classic.
Trunk, extremities.
Boom.
Done. You know it now.
Head,
Awesome.
knees and toes.
Hey, Briggs, let's do another short. We're going to do this short is going to be on measles and complications from measles.
Yeah, so let's talk about the incidence of these measles complications. We're looking for the most common overall and then the most serious, the scariest one.
Okay. So the most common is going to be acute otitis media. That's going to be upwards of almost 10%. So anywhere from like 7 to 9%. So of 100 kids, almost 10 of those are going to get acute otitis. What else, Briggs?
Yeah, what's a leading cause of death of
Leading
patients with
cause of
measles?
death, right, is going to be pneumonia. Incidence of this is about 6 to 13% from a complication rate, but that's also the leading cause of death for measles.
Yeah. And then much less common we think about what going on if they come with ultramoral status.
Encephalitis.
Yeah.
So that's about 1 in every 1,000 cases are going to develop encephalitis. Death from measles is about 0.2%. So out of 1,000 kiddos, you can expect, unfortunately, and about 20 of them will pass. That's in developed countries, by the way, Briggs.
Yes.
In countries that are, developing, don't have the adequate resources, it's like 5 to 10%.
Yes.
It is massive.
Yeah, so what are the takeaways here? I guess the treatment takeaways, there's not much you can do here. It's just going to be a time thing. So yeah, just like a viral illness in general in children, it's you're alternating Tylenol, Motrin, intense amount of hydration, vitamin A supplementation has maybe been shown to reduce mortality, morbidity.
Yeah.
The biggest thing is that the rash takes time. It takes time. It spreads slow. And as long as they have that rash, they are considered infectious. They can spread that infection. So this is not just a droplet precaution either, like the flu. These are airborne isolation. Measles is extremely contagious, much more contagious than the flu and COVID. And so just keeping that in mind in terms of airborne precautions, if you are concerned about a child that has this in your department, it's airborne isolation. Do they all have to be admitted? Not necessarily. If they look really good and it's all just supportive care and the child's healthy overall, sure. But of course, like the standard things apply for viral infections. But I would have a very low threshold actually for any one of these children coming in to get an X-ray, just because of the high mortality of pneumonia associated with them.
Yeah. And you're saying low threshold to get that X-ray.
Exactly.
Exactly.
Right. Yeah, exactly. And obviously, the same precautions for complications apply for any other virus, meaning premature born, of course, high risk of death, other comorbidities, congenital heart disease, et cetera. All those things make it even more likely for that child to have complications from measles. That's really it. Let's wrap it up. Have fun out there.
I think the last thing, though, again, things going from 0 to 100, a lot of it is, reporting this to the health department.
Of course, absolutely.
So people know about outbreaks and things like that. You should find out what your, local state does, for these and what the pathways are for them. We did want to make sure that everyone got a primer on measles and especially on how to distinguish it as well. So
hashtag Tamiflu doesn't work. That's our tagline for one of the shorts.
Oh my gosh, yeah.
When Tamiflu doesn't work.
When Tamiflu,
as AK, it never works. All right, we'll catch you later.
That's awesome. Yeah, Briggs. I'll see you later.
See you later.
Hopefully this helped.
Best of luck to you.
All right.
Stay safe out there.